Wonderful. Thank you so much. All right. So I think we'll get started. So hi everyone, and welcome to today's webinar to mark World Schizophrenia Day. In fact, it's World Schizophrenia Week this week, so I'm sure you'll see references to this all over social media, quite rightly, to raise awareness of this illness. My name is Kate. I'm the Community Engagement and Events Coordinator for IHMRI. And today, IHMRI has partnered with Community Mental Health Care to bring you information on the research that's happening into schizophrenia, and also let you know about the different services that are available to support those with schizophrenia, and also support the carers of people with schizophrenia. Our panel will be here for the next hour to answer your questions. So please make use of the Q&A option at the bottom of the webinar screen. Type any questions that you might have into that box, and I will do my best to get these to our panelists and have your questions answered. If you want to share any experiences that you've had or make any comments at all, then I encourage you to use the chat function, and then we can keep an eye on what's going on that as well. A recording of today's webinar will be available. I will send that round to everybody who registered shortly after the webinar. And just a little bit of a background about IHMRI. For those of you who don't know, the Illawarra Health and Medical Research Institute, better known as IHMRI, is a not-for-profit charity, and our goal is to support health and medical research in the Illawarra Shoalhaven region. Our goal is to bring our scientists, doctors, health professionals together to help solve our greatest challenges. We do research into a whole number of different areas of diseases such as cancer, diabetes, mental illness, and dementia, just to name a few. Please check out our website, ihmri.org.au, to see the whole breadth of research that we do here at IHMRI. So according to the World Health Organization, 69% of people living with schizophrenia are not receiving adequate care. And schizophrenia is actually really common. It affects roughly 1 in 100 Australians. And as the research into schizophrenia continues, we are discovering better ways to treat the illness and really kind of unpack and help to remove the stigma that surrounds this condition. Our panel today is made up of experts in this field, and I'd just like to say a huge thank you to our panelists for giving up their time to talk today. I'd also like to extend my thanks to supporting bodies such as the IHMRI and Schizophrenia Research Institute, as well as the community who have facilitated and allowed this research to continue. So today you'll be hearing from IHMRI and UOW School of Medicine researcher, distinguished Professor Xu-Feng Huang, who has made significant contributions to combat obesity induced by diet and antipsychotic drugs. We also have IHMRI and UOW School of Medicine researcher, Associate Professor Kelly Newell, whose research focuses on the neurobiology and treatment of mental illness, including depression and schizophrenia. We have Harry Mendoza. Harry is Community Mental Health Care's vulnerable persons senior clinician and a social worker with a strong focus on schizophrenia. And we also have Professor Nagesh Pai, a professor of psychiatry from UOW, but unfortunately, Professor Pai is unable to join us today. He has sent through a recording, so we'll be showing bits of that recording during the presentation. And in fact, we'll start with the recording from Professor Pai. Hopefully the sound is okay. It's just going to give us a really good overview of what schizophrenia is, the symptoms to look out for, and the impact it can have on those people experiencing the illness.
Good morning. I'm Professor Nagesh Pai from the University of Wollongong. I would like to thank IHMRI for organizing World Schizophrenia Day webinar. I'll be talking about some conceptual issues about schizophrenia. Schizophrenia is a disorder of the young. over 20 million people worldwide are suffering from this illness, which unfortunately produce significant disability for the sufferers and their caregivers, and also reduces their mortality by about 20%. Schizophrenia is characterized by what we call as positive symptoms, where the sufferers experience various perceptual disturbances, what we call hallucinations, and variety of belief systems, including suspicions called as delusions. They also have negative symptoms, which potentially causes significant impairment in their functioning, including self-care. The cognitive symptoms create a significant challenges with respect to taking medications and even often a barrier for them to seek support. Lack of insight or awareness of impairment would make them not adhere to treatment and engage themselves in getting themselves better. Despite having good medications, they have a variety of medication-related side effects which complicates the illness. Unfortunately, the stigma associated with the illness, the financial constraints, and the difficulty in accessing treatment, apart from their attempts to self-medicate with recreational substance use, complicate the course of schizophrenia. They do have a significant reduction in life expectancy as a result of not only the illness itself, but concomitant other psychiatric illnesses and other medical illnesses. Despite we wanting to achieve a good functional outcomes, it is often challenged because of lack of relief from negative symptoms such as reduced speech, limited eye contact, reduced interest, reduced emotional responsiveness, and inability to engage themselves in social activities. This results in forming a therapeutic alliance, causing significant impairments in occupational and social functioning, resulting in sustaining their relationships, eventually causing a reduction in quality of life. Schizophrenia is a progressive illness, and those who experience this illness have recurrent relapses, and clinical deterioration occurs in this context of relapses. While clinical deterioration is maximal in the first 5 to 10 years of the episodes, it is crucial for us to intervene earlier. We also know that the longer the duration of untreated psychosis, worse the prognosis. So, number of relapses may be related to greater deterioration in the initial critical years, and this illness-driven decline in functioning plateaus rest of the life, resulting in they have challenges in recovering completely, and they remain with residual symptoms causing significant disability to their life.
Kelly, I wonder whether you might be able to give us a little bit of an insight as to what's actually happening inside the brain of those people where schizophrenia presents.
Thanks, Kate. Yeah, happy to. So I guess there's a bit of background in terms of what we're doing to try and uncover what is happening in the brains of those people that have been diagnosed with schizophrenia. We do a lot of work and collaborate with a lot of brain donation centres around the world to really look at the molecular level of the brains of people who have had schizophrenia during their lifetime to try and pinpoint what is happening at the molecular level, because we really need to understand that so that we can make better treatments and guide better treatment approaches. So we do a lot of work looking at different neurotransmitters or chemical signals in the brain to try and figure out, well, which chemicals are altered, and not just which chemicals are altered, but which parts of the brain are they altered in. And as Harry and Xu-Feng mentioned, there are a range of different symptoms in schizophrenia. So we have the hallucinations and delusions, we have the negative symptoms, which are often characterized by social withdrawal and a lack of affect. And we also have the cognitive dysfunction that can underlie these symptoms as well. So we're doing a lot of research to try and determine which molecular changes might contribute to different symptoms. We know for the positive symptoms, for example, the hallucinations and delusions, and it's pretty widely accepted that an imbalance of a chemical called dopamine in a specific part of the brain really triggers the onset of these hallucinations and delusions. And part of the reason we know that this dopaminergic system is imbalanced is if we have a look at antipsychotic drugs that are used to treat schizophrenia, these drugs are not successful for all people by any means, but largely they are helpful in alleviating these positive psychotic symptoms. And the way they do that is by targeting this dopaminergic system. There's a lot of side effects and a lot of areas of the disorder that they don't treat, and that's where a lot of research is being invested in that space. So there's a lot of evidence to suggest that another chemical called glutamate is involved in schizophrenia, and particularly that its disruptions in this chemical contribute to the cognitive and the negative symptoms of the disorder. And that is a particular area that we're focused on here in my research group, is trying to determine at a much more, I guess, cell level, whereabouts these glutamatergic dysfunctions may arise. And the other thing that Xu-Feng and Harry alluded to is that people with schizophrenia may present with different symptoms. Not every person is presenting with exactly the same mix of symptoms. And so one of the challenges with our research is trying to find, well, what molecular changes are consistent across the board and what might be specific to subgroups of people with schizophrenia. And one of the areas that researchers have been focusing on of late is inflammation. So there is a lot of evidence to suggest that people with schizophrenia have heightened levels of inflammation in the brain, but that is more prominent in a subgroup of patients. And so the trick now is to identifying which people during their life could be categorized into these different subgroups. The other thing that we know about schizophrenia is what we classify as a neurodevelopmental disorder. So while it often presents at adulthood or late adolescence, there is a lot of evidence to suggest that these changes in the brain start really early on in development in utero. And the reason we know that is there's lots of evidence that the genes that are involved in schizophrenia are genes that regulate some of these important neurodevelopmental processes. So in terms of some of the genetic changes in schizophrenia or the genetic alterations, I guess there is a hereditary nature in some cases to schizophrenia. We know there is that genetic, someone who has had schizophrenia, their family has at a higher risk of developing schizophrenia. But there are also a lot of people that develop schizophrenia that have no evident family history. So with the genetics of schizophrenia, it's not always this family passing down of genetics, but these spontaneous mutations in certain genes that then cause this cascade of events. And then there are certain alterations in brain development. Not that you can see with the naked eye. To the naked eye, the brain looks, you know, as standard as the next brain that you would look at. But if you look at it down the microscope, some of these chemical imbalances are there, but also some of the, what we call synapses, which is how neurons or cells in the brain communicate with each other. These synapses, there's evidence that there's not as many of them and they're not working as they should be. So that gives us a bit of an insight into the areas that we need to focus on when we're looking at what might be altered in the brains of schizophrenia.
Wow, it's just fascinating, Kelly. Thank you for that. So you mentioned that not all treatment will work for all people. Xu-Feng, I think could you give us a bit of an idea about the kind of treatments that are available, and then the impacts that some of these medications, say, might have on a person's overall health as a result of taking the medication?
Like Kelly mentioned, this disease is really the multifactorial involved in various aspects, brain development, gene, environmental factors. Then we look at the disease, the symptom itself. It's also quite a variety. And even the same person at a different state, they might present to you the different symptoms. As you can imagine, the whole thing is a very diversified, complicated system. By saying that, it doesn't mean there's no good treatment. I must say, in terms of treatment, the science is developed. It's incredible, effective in many aspects. For example, to control the positive symptoms, so a certain degree of negatives. But it doesn't mean we have everything for the treating the patient. Answer is no. For example, cognitive deficits, so the drug has a really minor effect. Some states have some effect, sometimes they don't. Therefore, for the last 66 years, since the first antipsychotic drug developed, there are a lot of improvement. This is called the pharmacotherapy, still the first line of the drug, particularly to those acute phase. So this is very important that there are still a lot of things to improve. Like we just say that there are side effects, different drugs have different side effects. First generation antipsychotic drugs really causing the motor dysfunction. Then the second generation drug, the currently widely used, 80% and above, can cause metabolic disorders such as obesity. In fact, the really cause the death for the patients is not the schizo itself, but mainly due to those really the side effects like obesity, cardiovascular dysfunction, etc. So therefore, when we look at the patients, when the patient takes the therapy, this is the one of the main major sign that we should really care about the patients. So by saying that the pharmacotherapy is not the only one, there are many others already implemented in the clinic. There are many still in the pipeline of research. I'll just give a couple of examples in that area in terms of the therapy. For example, psychotherapy, I'm sure Henry will talk about it. Psychotherapy is very important, meaning talk to the professional, like doctors, psychiatrists, psychologists, get some communication with family member, encouragement, solve the problem professionally and non-professionally supported. Therefore, the patient can figure out a way, maybe they can figure out some way to control for themselves, make it, in terms of thinking. That's a very important aspect of the therapy. So other things like the behavioral therapy, purposely doing something, occupy your thinking, make something. Many people, these people are really very clever, very creative. Therefore, you will see those therapies, music therapy. They create some music, enjoy the music, not even not thinking of their brain dysfunction all the time. Then you have even the garden therapy, doing some gardening. Those are all being reported are very helpful. From the society, like a social therapy, we should not really discriminate any of those patients. They are biological, they have DTD disease, like any other diseases that deserve the respect as any other disease, if they got a disease. And in addition to that, like Kelly mentioned, that there are also at a certain stage, a certain population, you have this inflammation. Therefore, inflammation could be a part of. Therefore, something like a diet, they thinking maybe can contribute some aspect, something that is really called an inflammatory diet. Some food causes inflammation, like saturated fat or high body unsaturated. There are papers have been published in research stage. And also the estrogen psychotherapy, people working every way to trying to work on to help the patients. So by saying all that, just a brief coverage, I want to just emphasize one word to cover all. This is the precision. The all we call it personalized medicine. There's no single pill to treat all the patients, all the stages. There's really no such a thing. So therefore, the care, good monitor, personalized medicine, and based on a different genetic background, diet at different stages, that's critical, important, in my view. This is one aspect. Do I have more time to talk? I can keep
a couple more minutes. Yeah.
A couple more minutes. Thank you. Maybe I'll just focus on one, the obesity, the antipsychotic drug induced obesity, the second generation antipsychotic drug, including clozapine, olanzapine, risperidone. Those drugs can cause obesity metabolic syndrome. Not everyone, high incidence. From epidemiology, it is around 46% patients get a such very degree of metabolic syndromes. Metabolic syndrome means obesity, means the central obesity, a lot of fat stored in the visceral organs, like the tummy. And also it can cause the hypertension, cardiovascular disease, dyslipidemia, type 2 diabetes, 5 criteria for the metabolic syndrome. Not only one institution, number of institutions around the world, including the survey in Sydney group who did epidemiology, the main death caused the patients will be the cardiovascular heart failure. Maybe that's not represent the entire world, but it certainly gives us alarm. So we need to be careful there for the patients. So for our group in Illawarra, really we trying to find out on the pill which component on the pill that are causing the metabolic syndrome. This is where you use computerized the generate different compound. We generated close to 100 compound. Then from there, we reduce to 3 to 4 testable molecules to test in the cell in animal model. Then actually over the last 11 years, I think the project has been very successful. Now we are funded by IHMRI to pursue further along that line. So which really, it will take time, but just let the community know we are working on it. We're working on it every day. It does take some time.
Yeah, thanks for that.
Thank you.
While we look at the treatment outcomes, our ultimate goal is to have a healthy, well life by restoring social, educational, occasional functioning. We also need to aim towards the optimal physical health. In a short setting, we worry about symptomatic remission, but it is important that we should aim towards social integration by treatment continuation and improvement of functioning. This is possible with a significantly effective and tolerable antipsychotic medications. While relapses are common, why not start treatment during the prodrome prior to the onset of psychotic illness? Can we prevent this? Unfortunately, despite identifying high-risk patients, we have a high rate of false positives. Large number of patients really do not convert from those high-risk symptoms into a frank psychotic illness. We don't really have a robust trials investigating the risk and benefit of interventions, and this lack of data on which treatments are most helpful and acceptable to patients is something which we need to really consider. We have over 70 antipsychotics worldwide available for care, yet the question is, What makes schizophrenia so difficult to treat? The bigger challenge is the partial adherence. We know every 3 out of the 5 patients do not follow their antipsychotic as planned. We know that quarter of our patients are partially adherent within the first 2 weeks of discharge, and interruptions in treatment over more than 10 days can double the risk for rehospitalization. More than half of our patients discontinue treatment within the first 2 months of the first hospitalization, and patients who treated irregularly are more likely to relapse than those who continue treatment on a regular basis. And these relapses causes long-term symptoms and disability. They increase the risk for suicidal attempts. It also causes progressive decline in the brain functioning and decrease in subsequent treatment response. They cost a lot more to the society, and there is an increased burden on the family and caregivers, resulting in a negative impact on health-related quality of life. While we are lucky today to have a large number of newer drugs, which minimizes the traditional side effects of antipsychotics, such as Parkinsonian side effects and irreversible movement disorders such as tardive dyskinesia, we need to be mindful that newer drugs do have certain safety concerns, particularly with regard to metabolic side effects and cardiovascular diseases. And my subsequent speakers would talk about that in greater detail. Ultimate aim of treatment is essentially to help them recover. In schizophrenia, recovery means not only symptom remission, it's also important that they get back to their work or school. They form important social peer relationships, and they live independently. And this is possible if there's a comprehensive, continuous, coordinated, consumer-oriented service. Thank you very much.
Couple of comments here. It would be great if doctors could explain to patients in more detail about metabolic syndrome, and that might improve compliance. And I assume the person that's commented this, when I was looking at Professor Pai's presentation, he was talking a lot about the often challenging adherence to taking medication, and that can then cause more problems. So I understand if people understood more about, or people were given the information they needed to, really to drill home the importance of continuing medication and not stopping themselves because they feel bad, that maybe that would be really helpful as well. And somebody also commented that a dietitian would be helpful too. Harry, I saw you nodding a lot to some of the comments that Xu-Feng was making. Is there anything you'd like to add around the current treatments that exist and what you've seen?
I think I would just like to agree with Dr. Schzophrenia on what he's saying about the side effects of the medication, metabolic syndrome. It's quite common with the clients that we work with. And I think my point to come across that capture on that presentation by Dr. Xuan is the actual also improving the other aspects, not just the biological vulnerabilities of a consumer, but how do they cope with stress? Do they have supports in place? And I'm going to explore that further in my presentation, because that's the other things that we have to look at. There's some other aspect, although medication is important to consumers' journey to recovery, but there's also some aspect that we can improve so that we ensure that they're not on the maximum medication that will cause them side effects, actually cause less harm to our consumers, and manage the symptoms as well at the same time by managing some aspects of their life.
Okay, now maybe we just, if you have time, just want to add a little bit more there.
Say that again, sorry, Xu-Feng?
If I have time, I just want to add a little bit more there.
Okay.
So you see in terms of the patients, when I did a review in that area, in terms of time progress, it's mainly in the first 3 to 4 months. when they develop the obesity, they gain weight. It's not that the linear go all the way, but it's at the early phase. So in the early phase, because we are saying nearly half you will develop obesity in second generation antipsychotic drug, particularly olanzapine, then this is the time-wise at the early phase is very important. Within 1 year, from epidemiology is 7 kilograms. That's pretty severe, just in terms of fat. We're talking about the adult, it has nothing to do with the growth. Therefore, at the early phase, and it's quite important to not let it deep to happen. Trying to figure out some way, listen to the people, professionals like Henry. So and then since you develop the metabolic syndrome, number one, the most important among all is the psychological. On top of that, the food intake, the activity. It is about energy storage. Therefore, those are the two key things. One is the intake, how much you really eat. Then what type of food you eat, very high saturated, high energy, and less activity. Once you sit there all the time, those are the factors. This is called a preventable strategy. So you can do something to it. Surely there are many other things that can be implemented in terms of the question. Thank you for the question raised. That's not uncommon.
So it would be really helpful for patients to have some access to dietitian support and help to reduce the symptoms of obesity, or to reduce obesity or chances of obesity as a result of medication. Harry, could I jump to you? Would you like to just give us a bit of an insight as to what you do in the other treatments that are available that aren't medication?
Yep. So I think, as every one of you know, my name is Harry. I'm a social worker by profession. I'm currently a senior clinician in Illawarra Community Mental Health Service. So I have 7 years of experience working in mental health, both in patient setting, community setting. I work in the adolescence unit as well, and also work in emergency department. And I do believe this is an area where people can make a difference, which is mental health. So thank you all for inviting me here today. With the limited time given to us with this presentation, I will just try to aim and capture and give you guys a bit of understanding of what we do in community mental health. I'm going to take you guys to the journey of the intervention that we provide to our consumers, to people with a diagnosis of schizophrenia, and hopefully I can give a bit of a snapshot of all the passionate work and colleagues that I work with in community mental health. So to start with, I'm going to talk about the referrals. So majority of referrals that come from community mental health, they come from hospital. People that got admitted because of a psychosis, they get referred to us for a follow-up. And we also receive referrals coming from the mental health line. Parents, families calling the mental health line, concerned about the behavior of their family member, and they want us to follow them up for a mental health assessment. We got people who walk in as well, being sent by their NGO workers or probation and parole workers to conduct a community mental health assessment, and that's what we do in community. So as you say, Kate, there's about 1 out of 100 people with a diagnosis of schizophrenia in Australia. In 55% of, I did a bit of a statistics of how many people that we're working with, specifically just in care coordination team, which is previously known as the case management team. We're looking about 55% of people who are working, that we're working with a diagnosis of schizophrenia that are registered in the last 5 months in our service. So we are 55% of that. So majority of the clients that we work with have a major mental illness, which is schizophrenia. So the consumers that we work with also have different identified vulnerabilities that makes it more challenging for consumers, for the families and community support and clinicians that working with them. So vulnerabilities include homelessness, DV, experience of DV and sexual assault, background of trauma. We're also looking at financial stressors, consumers that had brain injury, cognitive impairment, and all this type of vulnerabilities. So in community mental health, we work as a team. There's a specialized team coming from different professions. So we have occupational therapists, we got social workers, we got psychiatrists, peer workers, we got clinical psychologists, and we work together as one as a team to assist and provide that holistic and comprehensive care to our consumers that is specialized, what they need at that time on their journey of recovery. Um, so once the consumer get referred to us, for example, a consumer get referred to us, let's put a name on it. Let's put Dave get referred to us. We conduct a very comprehensive assessment. We look at what are they up to in the journey, what led them to be referred to us, and we do a non-judgmental approach, a trauma-informed care, and we also look at the different aspects, the psychosocial. We provide a psychosocial assessment to our consumers, and we work closely with their families to actually understand what led them to being referred to us, what treatment has they attempted in the past, what are the things, all the all the collateral that we can get from the people that know the consumer and the consumer itself, and we work closely with them so we can identify and understand where they at that time when we do an assessment. So for example, if they get referred to our service, we also look at the Maslow's hierarchy of needs. After this assessment, will Dave have a place to stay home tonight? Will they be a shelter? Will Dave have food to eat? And things like that. So we also consider that in our assessment. During the process, we understand that engagement is very essential in working with our consumers, building that therapeutic alliance, and that we can promote trust and transparency between working with the consumers and their families. We utilize a very strength-based approach where we don't look at the deficits, but we look at the strengths of our consumers and work with them moving forward and identify what the goals that they have, and that all encompasses what treatment plan are we going to do, what care plan are we going to do moving forward. So we utilize a lot of motivational interviewing to actually align their goals. For example, Dave's goal is I want to live independently. I want to be able to work. I want to I want to I want to get a job. I want to get a girlfriend and things like that. We work with them, and we work with them to the different stages of change. And we use a lot of motivational interviewing to be able to do that. So we are aware that the importance of medication to treatment and relapse prevention, but we are also mindful of the side effects of it. That's why we work closely with GPs. We do a physical metabolic screening that we do all the time with our consumers. And what in my reflection in my own practice at the moment and working in community mental health, we're actually, as I mentioned, the consumers are actually receiving appropriate treatment, but we are not causing more harm to our consumers, and we are looking and focusing also at the different aspects of their life, whether that's improving their housing situation, improving their social connections, building some skills to manage this stressful situation when symptoms comes in. And we use a lot of evidence-based approach, as Dr. Feng once said. There's that cognitive behavioral therapy, there's that dialectic behavioral therapy, there's mindfulness, and we work with our consumers to actually build that, and also being mindful of what their strengths that they have, because they're also resilient, and that's what we're working on with our clients. So in line with medication monitoring and administration, we pride ourselves in providing a lot of psychoeducation to our consumers and our client. We want them to understand what we know about their illness. They need to know that. They need to know what their illness is, what are the symptoms of the illness, because the better knowledge that they have about their illness, the the better they're involved on their treatment progress. And we also work closely with the families and letting them understand that about what the illness is and what are the things, and we are transparent of what kind of medication we provide, what are the side effects, and we work with them. We also talk to the consumers about what are the impacts of substance use when you use substances, to the actual us providing you with medication and then you using substances on the other hand. So we do a lot of psychoeducation as well. So majority of our intervention, we base it by stress vulnerability model. So you got the biological vulnerabilities, which is the importance of taking medication, and then the other side you have the impacts of substance use. And then on the other side is the stress, like the level of how do they cope with stress. And then we also talk about how to build their supports, and we work with them together in building those things so that we ensure that they don't relapse. Um, when it comes to relapse prevention, we talk to our consumers about the importance of identifying early warning signs of their illness, working towards prevention plan, not just doing a plan, but also practicing this plan moving forward. Because our aim when consumers get referred to us, we want them to manage their illness. We want to build their skills so that they can manage their illness so that they don't come back to our service. And we work together with different partners as well. We're not alone in this journey. We have good services around that we utilize. We got people that provide psychosocial support, whether that's through NDIS, psychosocial support through Wellways, NEMI. So we work closely with these people. We got family and care support like Stride that we work closely together to ensure that we provide the best service that we can provide to our consumers. So I guess just for conclusion, I just want to read a very beautiful quote that I that I that I read from a consumer. It's dated 1989. So one of the few things that was mentioned is this consumer said, if we do acknowledge and seriously study our illness, if we build on our asset strengths, if we work to minimize our vulnerabilities by developing coping skills, if we confront our illness with courage and struggle without symptoms persistently, we will successfully manage our life and bestow our talents on our society. So it's a very powerful quote. So that's what we're aiming to do. We wanna build the other aspects as well. So the journey to recovery can be a very long journey. It can have bumps along the way, and hopefully our intervention that we provide during that encounter that we have with them can provide that skills so that they can go through the bumps safely and get back on track towards their goals. However, if there's a need along the way for us to be involved again, whether to be just a backseat driver to their journey or just be a passenger seat on the journey, providing them some coaching and reminder, we will do that as well. So the journey to recovery, different journey are different, but we ensure that we hopefully can provide some impact and change to that consumer life.
I have no doubt that your service does, and it's wonderful to hear that the goal is to empower the people that come and see you with the skills that they need to help to manage that themselves with the help of their family support networks. That's really great to hear. And actually, you mentioned around substance abuse. I do have a question here from Ashley, and she wants to know, can substance abuse cause or accelerate schizophrenia, or is it merely a coping mechanism for many who have schizophrenia? Would anyone be able to answer that question? Whether it accelerates the symptoms from schizophrenia, or whether it is just a way that people can better cope with what they're experiencing.
Yep. So who wants to answer first?
Okay, Harry, I do have some evidence from the literature. If you first,
I think I'll let you do that first.
Oh, you do it first. Yes, answer is yes. In particular, at the critical stage of brain development, there are very strong evidence actually in the literature. The teenagers, particularly in the certain stages of brain development, for example, in the teenagers, the young people take marijuana. The outcome to that is 6 times higher to develop schizophrenia than the controls. That's well-designed study from Europe. Therefore, during certain, the brain development, they have a special window stage, and they have, for example, at a very early stage, just in the child was born, a larger number of cells form. After that, it's really the cell-cell communication, particularly in the later, when the brain development at the age of 16, 17, 18, started to finalize, trim off all the unnecessary connections, keep the connections they are required for the brain function. At that stage, so the brain cannot be disturbed. When that stage, young people take marijuana, it's very dangerous. It's not good. So it's well recognized in the literature, particularly any brain toxic drugs can cause some serious problems. And we're going to go through the whole any stage, but at a particular stage, it really linked to schizophrenia.
Thanks, Xu-Feng. I have another question here that somebody submitted prior to the webinar. And she wants to know that she's heard people living with schizophrenia, specifically males, tend to have a shift to a more stable mental health around the age of 40 when hormones may be shifting or leveling out. Is there any truth in this? Is anybody able to expand on that? Or should I get back to
Harry, you want to go ahead, or you want me to talk my view?
Yeah, the evidence-based information that you have.
Yeah, actually, I got this question a couple of weeks ago. It's not the first time I got the similar question. I did went to a few doctors to ask them, senior doctors, ask them their opinion, and also I checked the literature and then trying to get some more, not any single doctor say something. So really trying to come to like the good, solid evidence-based medicine from that angle. In terms of the entire course of the disease from early last for 20, 30, 40 years, I just want to make 3 key points here. Number one is when the first attack, first psychosis at the time is quite important. The early, the worse. That's in general speaking. If the person 40 years of age started to get the disease, it can happen. So the symptoms relatively minor compared to the early onset. That's number one point I want to make. That's from the consultation and also the literature. Number two is about for example, the male entire course. So it's very common when patients come to the clinic show the positive symptoms, psychosis, which is those hallucinations, etc. They come to the clinic. So that's the first. Then it doesn't mean all the patients show the same, but it's a very common psychosis start with. Then after a few years of the treatment, etc., then gradually they then less positive symptoms because the antipsychotic drug are pretty effective. Then they can move to the negative symptoms, many. Then with the time goes by and cognitive deficits become quite a major problem because we don't have any effective way to improve cognitive function in schizophrenic patients. Now, saying that gives you an overall feeling that the symptoms getting better and better. But actually, I got a couple of doctors who said to me, that's the wrong impression. Negative symptoms is as bad, even worse than could be worse than the positive, because positive is easy to control, negative can last a bit longer. So they don't feel we should give any release in terms of therapy or care. They should be cover all the stages. That's will be appropriate advice to the patients. And then at a later stage, they can become slower. Anything, they hard to make any decision because cognitive function decline, etc. But at that time, they still need a good care. With the people cannot cope, this has to be throughout the entire life. We cannot say that later stage we can give up. That would be the wrong, according to what I consulted over the last couple of weeks. So that's from a number of the doctors, clinicians. that's through the whole entire their disease process. Harry, Kelly,
You captured that. You captured that very well with evidence-based backing. Yeah.
Kelly, did you want to add something to that?
Yeah, thanks, Kate. Yeah, I guess I just wanted to add there's a lot of evidence that women have a much later onset of schizophrenia than men, suggesting that estrogen is quite protective for women. And post-menopause, there is another spike in women being diagnosed with schizophrenia. So this evidence that estrogen is protective, so women also don't tend to have as worse a prognosis as men, has led to a lot of research into new therapies to see if we can target estrogen as a potential novel therapeutic for the treatment of schizophrenia. Because estrogen isn't just about the female body and reproduction, it also signals in the brain and regulates a lot of our brain function. So this information of this protection in women has led to a lot of clinical trials looking at estrogen modulators targeting the brain and how beneficial they might be for the treatment of schizophrenia.
Thanks, Kelly. And somebody had mentioned.
Okay, I just want to add another point. By saying that we have a number of treatment strategy there, it doesn't mean there's every patient get a good. There are still quite a high percentage in terms of this disease does not respond well to the treatment. Still exists. They are not universally the same response in terms of the drug. Therefore, according to the epidemiology, it's about 27%. So they do not really respond as good as others. So we keep that in mind, that this is a pathology. There's nothing to do with the person. Sometimes we have to be patient. Some patients, they don't want to take the drug. They say they take the drug, they don't. So we've got to be patient. That's a disease. So some patients, they do not really respond very well to a number of the treatment. Therefore, the research is required. The researchers in the field, they know. So they're trying to figure that out way. A lot of effort still put into that for the good future.
I guess that's where I wanted to go to next, is that we've spoken about the treatments that currently exist, different types of medication and CBT and other types of therapies. And Kelly, I know your work focuses a lot on looking at new treatments that might help relieve some of these symptoms. You've mentioned estrogen already. Is there anything else that you're working on or that you and your colleagues are looking into?
Yeah, definitely. There's a lot of areas that people are looking at across the field of what could help people with schizophrenia, and touching on even exercise that you were talking about before, Harry and Xu-Feng, as essential for managing the side effects. Exercise itself is also shown to increase the growth of new neurons in the brain, and in doing so is helpful as a co-treatment for people with schizophrenia. But there are also, even just last year, a new drug called lumateperone on the market. It's a bit of a tongue twister, that one, which is slightly different to the current second generation antipsychotics because it targets dopamine and glutamate, but it also doesn't target some of these brain systems that we know contribute to the weight gain side effects. So that is a promising area that's looking at. There are a lot of clinical trials into new drugs targeting different systems such as the glutamate system, and they've been really promising. Unfortunately, COVID has put a halt on clinical trials at the moment, but hopefully in this post-pandemic world, these clinical trials can get back underway and we can transition some of these drugs onto the market soon.
That's great to hear, Kelly. I mean, that's I guess the beauty of research, that there could be treatments out there that we just aren't aware of yet, which is why I guess the importance of support from funding bodies and of course the community as well to enable the research to continue. Just on treatment, I just want to get one last question in, and I apologize to those people who have asked questions and we've not been able to get to them. I will share these questions with our panelists after the webinar. We'll respond to you individually. but somebody has said here, sorry, Catherine has said she understands that some people don't respond well to different treatments that are available and still have active symptoms. Do we know why some people do respond and some people don't? And is there any way to predict how a person might respond to treatment?
So we're trying to initiate a project, actually, it's trying to see whether there's a special pathology or something in those patients. Actually, it's pretty hard. The criteria, world criteria, is 2 antipsychotic drugs that do not respond for a certain period of time, then can classify as drug-resistant patients. Now, in terms of the why, the pathology, it's still at a very early stage. That doesn't mean we will not have the solution because the science is moving so fast in terms of you see the gene sequencing, proteomics, the metabolic the profiles, all the techniques developed so fast. I will not surprise the first within the next couple of years, then some new information come out. I will keep this in mind. If I know anything, I will let the community know, because it is a big problem. It's scientists knows about that. Still, we don't know why they're resistant to the drug.
Great, thank you, Xu-Feng, for answering that. Again, apologies to those people who have submitted questions and haven't been able to get to them. We'll make sure we answer them offline. I can't believe an hour has gone by already. We never have enough time to answer everyone's questions, or as I'm listening, questions are flooding in my brain, and I just know that we don't have the time to respond to them, but that's given us a really great idea of what's currently going on and what is being developed for future treatment. So thank you so much to all of our panelists for supporting this webinar and for providing your expert views. And to all our audience, thank you so much for your engagement. I can see lots of different chats coming up in the chat function, and also the questions. I really appreciate you tuning in and listening to this. IHMRI puts out a newsletter every other month. So I do encourage you, if you haven't yet, head to our website, ihmri.org.au, to register to subscribe to our newsletter, because any new research that's happening, any exciting new developments will be put into that newsletter, that will help to keep you abreast with the research advances. Also keep an eye on our Facebook and Twitter pages at IHMRI to keep an eye on what's going on from a research perspective. And once again, look, I just really appreciate our panelists' time. I know you're incredibly busy, but it's just so wonderful to hear what's happening in this space. So thank you so much for getting involved in this webinar.
Thank you for organizing this.
Thank you.
You're welcome. Thank you.